is monitoring patients with anxiety who use adjunctive treatment for 1 month. My name is Myranda Whitman, and I'm a student at Maryville University. My DNP committee consists of my chair, Teresa Gallicatos, my community person, Elizabeth Robert, who is a peer of mine, a supervisor, and a fellow psychiatric mental health nurse practitioner, and the second reader, Lisa Stewart, who is the instructor for Nursing 707. A little bit of background, the CDC reported that in 2016, over 56.8 million outpatient visits were recorded within the past year with patients with mental, behavioral, or neurodevelopmental diagnoses. Of these diagnoses, anxiety was the most common mental health diagnosis. It's estimated that 40 million Americans struggle with anxiety, yet only around 1/3 of those diagnosed actually seek help. Anxiety treatments can vary, but pharmacologic treatments are common, including selective serotonin reuptake inhibitors, also known as SSRIs, such as Prozac or Zoloft, or shorter-acting medications such as benzodiazepines like Klonopin, Xanax, or Ativan. Having anxiety puts the patient at risk for hospitalization, as it can impair functioning and be detrimental to a patient's well-being. The aim of my project was to improve the quality of life for patients diagnosed with anxiety. The purpose of the project was to examine the anxiety levels after 1 month of adjunctive treatment and routine care. Adjunctive treatment for the purpose of the project was yoga, walking, bicycling, or meditation. Routine care would be defined as compliance with their anxiolytic medication. Significance of the project is to prove that evidence-based nursing interventions can improve patient outcomes. The research question is, in one outpatient mental health clinic population, how does adjunctive interventions such as yoga, meditation, or exercise impact outcomes? In reviewing the literature, I reviewed current evidence as to how adjunctive therapy, each option, has affected anxiety. In a study consisting of all-female sample group, participants who were not taking medication showed decreased anxiety levels after performing yoga 3 to 4 times weekly. In a different study, stretching was proven to decrease anxiety even just after 1 occurrence. When participants implemented exercise routines consisting of bicycling, walking, or jogging, anxiety levels decreased, then rebounded back up after ceasing the exercise regimens. Practicing mindfulness-based stress reduction, or MBSR, showed to have decreased both the physical symptoms of anxiety, as well as the cortisol and adrenocorticotropic hormone after 8 weeks. When mindfulness meditation was implemented in a separate study, scores on the tension anxiety scale and the anxiety sensitivity index both significantly decreased, showing an improvement in anxiety symptoms. When deciding what I was going to do for this project and what my purpose and aim would be, I reviewed the tidal model theory. This theory was developed by Philip Barker, and the purpose was for the healthcare provider and client to work together to problem solve and cope with stressors. This includes further examining how the problem affects the client and learning how to empower them to cope with the stress and live to their highest functioning capability. The tidal model theory is applicable to the project, as my aim was to empower participants to explore possible healthy lifestyle habits to use as a coping skill. The project utilized a quantitative method with a pre-test, post-test design. The surveys used for the pre-test and post-test were the Beck Anxiety Inventory, or BAI, and the Hamilton Anxiety Rating Scale, or HAM-A. Both of these scales measure various anxiety symptoms, ranging from physical symptoms, such as gastrointestinal upset and tachycardia, to feeling fearful and tense. Participants included were outpatients diagnosed with anxiety disorders who were taking anti-anxiety medication for a minimum of 4 weeks. All participants were between the ages of 18 and 80. The project took place at an outpatient mental health clinic in the Midwest. When participants completed the pre-test, they completed both the BAI and HAM-A to measure their anxiety symptoms. At that point, they were then instructed to implement the intervention, which was to do at minimum 1 adjunctive treatment for 30 minutes per day, 5 days per week for 4 weeks. Participants were given an activity calendar and responsible for capturing their activity on that calendar. When they returned 4 weeks later, participants returned the activity calendar to me and completed both the BAI and HAM-A again. These participants come in on an every 4-week basis to pick up medication, so they are regularly monitored and present at the facility. After scales were completed, the scores were compared between pre-test and post-test. These figures depict the demographics of the sample group. Figure 1 is the gender of participants, N equals 43. We had 22 females and 21 males. Figure 2 is the age of participants, N equals 43, with 22 participants between the ages of 35 and 64, 16 participants between the ages of 18 and 34, and 5 participants between the ages of 65 and 80 years old. Figure 3 is the ethnicity of participants with N equals 43. We had 35 Caucasians, 5 African American, 2 Latino or Hispanic, and 1 Asian or Pacific Islander. The population around this area is not extremely diverse, so a majority was Caucasian. To analyze the data, 2 paired t-tests were used. One t-test compared the pre and post BAI scores. The second compared the pre and post HAM-A scores. Paired t-tests were chosen for data analysis because they measure and compare values from the same participant at 2 different times. This graph lays out the results of the Beck Anxiety Inventory scores. The pre-test is indicated in the red and the post-test score is indicated in the green. Each of the 43 participants is listed across the x-axis. This figure makes it easy to visualize the difference between scores from pre-test to post-test. Almost every participant had a decrease in score after the 4 weeks. A decrease in score on the BAI indicates that the anxiety improved. Similar to the last slide, this graph lays out results, but for the Hamilton Anxiety Rating Scale scores. The pre-test is once again indicated in red, and the post-test scores are indicated in green. Once again, this shows a pretty drastic difference between pre-test and post-test scores, and almost all participants had a decrease in anxiety level or a decrease in score after 4 weeks. With a Hamilton anxiety score, a lower number means less anxiety. This table lays out the paired t-test comparing the values at 2 different points. Within this table, we have pair 1 on the top, which is a comparison between the Beck Anxiety Inventory pre- and post-test score, and pair 2, which is a comparison between the HAM-A. You can see that the mean scores for both the HAM-A and BAI decreased quite a bit. Both pairs had similar standard deviations around 7 and a p-value of 0. Again, reiterating the results here, the p-value for both paired t-tests was at 0.000, with anything less than 0.05 being considered statistically significant. The average decrease in score on the BAI scale from pre-test to post-test was a decrease of 11.55 points. The average decrease in score on the HAM-A was 13.81 points from pre-test to post-test. With the p-value being less than 0.05, results showed a statistically significant improvement in anxiety scale scores with the implementation of adjunctive treatment measures. This figure, the most common adjunctive treatment with N equals 43, shows the top implemented adjunctive treatment. Most of the participants chose one treatment to implement throughout the 4 weeks, although they were given the freedom to implement any of the 4 and switch between any of the 4. 22 participants implemented mainly meditation, 20 participants implemented mainly walking, 1 bicycling, and none of the participants strictly implemented yoga. The main limitation with this project was the lack of comparison group. Participants were taking anti-anxiety medication. Without a comparison group of patients who were taking anti-anxiety medication but not utilizing adjunctive treatments, we cannot be sure that the decrease in anxiety symptoms was due to adjunctive treatment measures alone. We cannot isolate the adjunctive treatment as the one variable to cause the decrease in scores. In order to minimize further limitations such as bias, participants were informed that they could withdraw from the project at any time without prejudice. Also, when it comes to measuring anxiety, the BAI and HAM-A were used both times, pre-test and post-test, making it a consistent measurement from pre to post. The decrease in anxiety leads to better outcomes. The results of this project are not generalizable. Results from this one patient population showed improved health outcomes due to lowered anxiety, but due to the lack of the control group, we cannot generalize before isolating the adjunctive treatment as the sole variable to decrease anxiety symptoms. The impact of medication on the project would need to be ruled out as the cause for lowered anxiety before results could be generalized. When looking at the needs for sustainability, this would be a relatively simple intervention to keep going for future use. Handouts with instructions have already been made, which provide patients with safety instructions and resources for activities. The time involved to continue to implement this intervention would be a few minutes, maybe 5 minutes or less, by APNs or registered nurses at the facility during their regularly scheduled visits. The nurse coordinator has already taken on responsibility for updating programs such as this and could manage this program moving forward to update the handout with more current resources and evidence as necessary. For our clients, adding adjunctive measures could improve outcomes. Quality improvement projects indicate practice improvement based on the evidence. This establishes a standard for nurses with advanced degrees that they should examine patient populations for areas that need to be improved. When looking at future implications for projects of this nature, it was noted to use a control group for more conclusive results. In conclusion, adjunctive treatments such as walking, bicycling, meditation, and yoga contribute to the lowering of anxiety symptoms. Practitioners such as APNs should educate on adjunctive measures and potential benefits to their clients. It's an intervention that does not take much time, energy, or resources, but could be extremely beneficial for clients. Mental health care is difficult to access, so educating on healthy habits that patients can do at home to help their mental health is extremely important, not to mention the holistic care that we as APNs strive to provide. Life has so many stressors and anxiety-provoking situations, even more so in the midst of a worldwide pandemic like COVID-19. It's imperative that APNs provide clients with the tools to cope, such as adding adjunctive treatments to their daily lifestyle. The tidal model theory states patients and providers should work together to find solutions to problems so the patients can cope and function at their highest level. This was the perfect theoretical framework to use for this project, as participants and I were able to work together to apply the adjunctive treatment measures to lower anxiety levels, which in turn can improve their functioning. If you have any questions, please feel free to leave them in the comments section of this video. These are the resources used for this presentation. Thank you.